Okay, good morning, everybody. We're just getting started right now, and we'll give it, as usual, a few minutes to get everybody, allow time for everybody to come into the room. I want to thank everybody for joining us this morning, and hope you're having a good week. Same as last week, I will be sending in the chat function some links for you to get CME, and again, thank you to our CME faculty for helping us. So that'll come through the link. Also send an email, as we do every week, either later today or tomorrow, with a link to the YouTube version of this video, as well as how you can grab CME. So don't worry about it if you don't sort it out this morning. For those of you who haven't, to get CME, you need to create a CME account for the first time. After that, it's much easier to do it in the future, and you can grab CME for all of the past grand medical rounds from us, as well as multiple other events throughout the School of Medicine through their websites. And I'll send that information all through the chat function, and again, it'll be in the email as well. As people come in now, Dr. Harrington, I'll turn it over to you.
Great, thanks, Earl, and as always, Earl, thanks for your leadership in getting medical grand rounds set up. Welcome again to, I think, what is our fourth medical grand rounds devoted to the COVID pandemic. This week, we're going to have, again, a similar format in that we will talk to our local leadership as to what's going on in the SHC system, including the emergency department. We'll hear from our colleagues in the pathology lab about some of the updates, including serology testing, which went live this week. We'll get updates on our inpatients, our outpatients, and then finally, the focus for today will be Drs. Upi Singh and Ken Mahaffey, bringing us up to date on what's going on at Stanford with regard to COVID-related clinical research. So again, thank you for joining us. We hope you find this valuable. Please send us feedback. And I turn it back to you, Errol, to launch today's program.
Okay, great. So we'll start off with Dr. Norm Rizk to give the first of the updates.
Okay, thank you, Earl. So today we're going to start talking about what's becoming of the surge. And I can have the next slide. So one of the things that's evident is that the United States, compared to all the other countries, has many more cases, and the top curve there that now is starting to decline, along with France's that you can see below it, is by far the most affected country. But there is this nice little beginning of a decline that is heartening. Can I show the next slide? So if we look in California, we have 15,000, almost 16,000 cases. And if you look on the right on the deaths, you can see that about a week ago, it was between 10 and 20 additional deaths per day. More recently, it's been in the 30 to 40 range. This morning's report, not yet on this slide, is 31. So it's, it's about 50 to 75% more deaths per day now than it was a week ago. And you can see by the bubbles on the left-hand side that LA is where most of this is now occurring. Next slide. So if you look in Santa Clara County, we've had 61 new cases in the last day. There's almost 1,300 cases. In the left-hand panel, cases by age group continue to be largely middle-aged. And on the right-hand panel, deaths by age group, you can see that most of the deaths are in the 70s and 80s population, a fair number in the 60s to 70s. And we continue to have the male disproportionality in deaths. 67% of them are male, and we continue to have deaths with comorbidities. 79% have comorbidities. So this is just continuing the same trend that we've seen in Santa Clara County before, which mirrors the nationwide trend of nationwide data. Next slide. So the University of Washington is probably the most commonly viewed site nationwide for what's happening in surges. And they recently revised theirs to estimate a much smaller number of affected people in California and an earlier peaking period. So the bottom graph with the purple shaded area reflecting uncertainty and the dotted line showing their best estimate has quite a few more patients in it than the current one, which is the upper panel. So that's how they've modified it from the lower panel to the upper panel. Many fewer cases, peaking at about 10,000. But you know, the actual number will be, they think, around 5,000. And then you can see that we have all of the resources we need in California. All the beds they're predicting are needed are 4,869, and we have 26,000 beds. And we have more ICU beds, 1,900, than the 800 or so that seem to be required. So all this is suggesting the surge is really going to be smaller and going to be sooner than we had previously thought. The next slide. If we look in Santa Clara County in the hospitals and at the doubling time in the hospitals, and this is Nigam Shah's data, culled from the county, all individual hospitals are the lines in each of those graphs. The ones on the left are hospitalizations. The doubling time's 18 or 19 days now. It was previously in the range of 6 to 7 days. And the ICU admission doubling time is not very accurate because it's so flat, but you can see the total number of ICU admissions has really stayed in the 60s mostly. Stanford's hospital is in the middle of that pile. So we're quite average in the number of cases that we have, and also in the doubling time, both in hospitalizations and in ICU admissions. The next slide. If we look at patients tested, the graph on the left, you can see that there's we've mostly been in the 8 or 9% positive range in Stanford Healthcare, more positives from the outside than from the inside. I want to make a comment about occupational health. In the last 2 days, we've tested around 300 patients, and we've only had 1 positive that was new. We've had some people coming back to work that were retested and that were positive previously, that were still positive. But the overall rate in occupational health is about 2.9%, but there's a trend towards there being fewer cases. And this reflects the safety, I think, of our PPE planning. And so our case doubling time in these estimates is somewhere like 30 days. These are not very accurate when they get very flat. Next slide. So why is this? We're just experiencing the same thing that has been going on in epidemics for over 100 years. This is a slide I stole from George Rutherford, a Stanford alum who's an epidemiologist at UCSF. This is 102 years ago in the influenza pandemic. In Philadelphia, they failed to shelter at home. And in St. Louis, they closed all the restaurants, pool halls, cabarets, lodges, public funerals. And this is the flattening of the curve, 100 years old. And if we don't believe it's still true, next slide. This is Lombardy in Italy. And the graph that shows the intervention in purple was in Lodi, where they sheltered at home. And then in Bergamo, they didn't do that until about 12 days later, and shelter at home, and that's what happened. So the timing of it is extremely critical. Next slide. Oops. And if we look in San Francisco and LA, the reason that we are experiencing a relatively small peak and an earlier peak is that we sheltered, that's the shaded area, well before the first COVID-19 death, which you could use as the index of when the pandemic is starting up. So we started early, and that's what we got. And in LA, they started days after the first COVID death, and that's what they got. So to conclude, next slide. We're right now enjoying some of the benefits of sheltering early. Our hospital census is about 50%. We have way more capacity than we need. This morning we had 54 empty ICU beds. We had 183 ward beds. We've closed down our surge wards, B1 and B2, D1 and D2, which are ICUs. We had positioned one ICU surge team. We disbanded that on the weekend. And at this junction, we remain ready with lots of staffing, lots of facilities, and more than adequate equipment. So I'll stop there. Thanks.
Great. Thank you very much, Dr. Rizk. Dr. Weinacker, would you like to comment now?
Sure. There's not a lot left to say. Want to give you a little bit of an update of what the current status of the hospital is. There are 13 COVID patients in the house, 5 in the ICU, all of whom are on vents. And there are 6 PUIs in the house, and we've had a number of people get well and leave the ICU. The medicine service has been really quite quiet. Nira said yesterday that the service has been as low as 37 patients on the whole hospitalist, all the hospitalist teams. Their usual is about 100 and can be as high as 130 when they're really pushed. And so it's really been quite quiet. Norm mentioned the ICU has been, the ICU surge team has been deactivated. There are currently 54 open beds in the ICU, 183 AAU beds. So we have 236 beds open. There are 347 patients in the whole hospital. And for a hospital that 6 weeks ago was at 620, this feels quite different. As far as other things that are going on with the court committee, the group that's been looking on a daily basis and starting today 3 times a week instead of 7, looking at our current processes, policies, guidelines for how to manage care, which is, as everybody knows, evolving very quickly as we've learned more and more about this disease over the last several weeks. There were some guidelines posted on the website, some yesterday updated and some earlier this week or within the last week, about how to protect providers or healthcare workers, not just providers, but even our housekeepers, et cetera, who have comorbidities or are pregnant. So those guidelines are on the website now. We had some guidelines for pregnancy, but we updated them yesterday. And just for information, pregnancy is really not felt to be a high-risk condition, but pregnant women are a protected group, and so we have been very conservative in terms of what we are saying for pregnant women to be able to ask for accommodations if they want to. Similarly with people with comorbidities. So, and then the PPE, just numbers that sort of surprise me. How many of the yellow masks that we use in a day is, our burn rate yesterday was, about 2 days ago, was 82,000 masks, which is just a shocking number to me. I thought it was shocking when it was 27,000. Now that it's 82,000, and we use about 1,000 N95s a day. So we really, we are actually in pretty good shape when it comes to our PPE, but we also are now burning through it a lot more quickly as we have universal masking. And so we do want to be aware of that and cognizant that it's not an endless supply, although we have been quite lucky so far. The county is now requiring that we tell them how much PPE we have, with the idea, we assume, that there may be some request that we begin sharing our wealth if we have a disproportionate amount of PPE. So I think that's enough for the moment, unless anybody has anything else that they wanted to know that I should have said.
That's great. Thank you, Dr. Weinacker. I appreciate it. Dr. Mahoney, can we switch over to you now?
Hello, good morning, everyone. Yeah, my report out will be brief because I want to allow time for the presentations today. So in ambulatory care, we are optimistic about what we're seeing as a flattening of the curve and are starting to really understand which services need to be sustained post a peak in order to allow us to, first of all, address what has been maybe somewhat neglected, and that's along the lines of preventative care and chronic disease management. And we know that if we amplify and focus on those efforts, that will lead to a prevention of ED and hospital utilization. You can see just the data here has been remarkably helpful to us, in addition to the county data that's been available, so that we feel confident about which clinical services need to be sustained, and we can anticipate the demand going forward. So I'm very grateful to Nigam Shah making this data available to everyone. And so as we start thinking about care post-peak, we're very excited to leverage what we learned around virtual care, the consultative skills, the physical exams that we can do, and bring that forward so we can optimize care that extends beyond the walls of the clinic going forward. And so we will continue to leverage that platform. In addition, we will continue to operate the highly efficient and safe platform for testing that has been developed in the 7 drive-through sites across the Bay Area. And our testing sites have supported Stanford's commitment to our surrounding community throughout the crisis. Through these targeted testing programs that have been developed for first responders, public safety officers, firefighters, and EMTs in San Mateo County and Santa Clara County. And there's a planned expansion of this service to other essential workers in the Bay Area who are nobly on the front lines working alongside us. So SHC and UHA Primary Care have developed a network of COVID care clinics and respiratory clinics that will be sustained post-peak and can be then scaled up in the case of a COVID rebound. The clinic will conduct a population health outreach, and the frequency and the mode of those services will be determined by age, comorbidities, and the severity of their illness, really providing the personalized COVID care. And as part of these clinics, we'll collaborate with researchers at Stanford. We're very excited about that. We feel very fortunate to have so many research partnerships, and we're involved currently in operationalizing about a half dozen projects now. And then along the lines of wellness, we are so appreciative to have the WellMD program so robust that it's allowed each of us to customize a wellness package. And then as we go forward and think about COVID and how it has developed us and helped us understand how we can be resilient and how we have really in heroic ways contributed to our families, our community, our patients. It's forced us to break away from the past a little bit and think about a world post-COVID, and now we get to really benefit from all of those learnings and really and start putting those into our practice in our professional life and personal life. So thank you.
Thanks so much, Dr. Mahoney. Moving over now, how about Dr. Sam Shen, the medical director of our emergency department?
Hi, can you get my slides up?
Yeah. Got those up. Okay. Sorry, Sam. Actually, you want to keep talking? I'm going to pull those up right now.
Sure. Hello, everyone. I thought I'd take this opportunity to share what we are doing in the emergency department to prepare for the surge. And fortunately, some of this data that we are looking at now is more favorable, which is a good thing, but still like to share what we have in store in case we do hit that surge and potentially even the disaster scenario.
Sorry, Sam. Actually, perhaps, Sam, I'm going to pull your slides up right now. And what I'm going to do is I'm going to ask Dr. Sang-ick Chang, do you mind giving us some updates? And then while I do that, we'll come back to you. Apologize for that.
Sure.
Any updates on occupational health?
You betcha. Here we go. Norm already shared the headline, so I won't belabor it too much, but we are also seeing the same trend all of the services are seeing, which is fortunately a flattening of the curve. We have about 68 total positive employees and faculty combined. We've tested about 1,800, and that's on a denominator of about 10 to 15,000 employees. So we've tested maybe 15%, and of those only 3.5% were actually positive. So that's incredibly good news. For some reason, our slide is not moving.
Can you reshare that?
Oh, there we go. Okay. And then this is just to show the overall demand. The blue line shows it's been relatively flat in terms of patients or employees having indications for testing. And we're liberalizing those as we go to lower and lower symptom levels. The orange are the new positives, and then the gray ones are the ones that are increasing, and that's the retesting, and that's kind of the interesting story. I won't go into this. I think you've seen this before. The people who are most commonly positive are doctors, nurses. The return to work story is interesting. It turns out there's a really long tail. We've now tested about 30 people who are otherwise asymptomatic and feeling ready to come back to work, and 75, and now it's increasing to 80% are still positive at 14 days, and only a quarter or a fifth are ready to come back to work even though they feel totally fine, and we can't really tell the difference in symptoms or date of onset or anything, and so this appears to be individual factors that determine how long they're shedding. We're asking all these folks to stay home. We don't know, of course, whether this is just fragments, remnant fragments of RNA that are inactive, or that they're active shedders and infective. But to protect the 15,000, we're asking the 68 to stay home. It turns out it's actually really stressful to stay home for that long, especially healthcare workers who want to be back on the front line. And so our wellness and WellMD colleagues and Tate Service has been incredibly, incredibly important. One other observation, new observation to share is that, as Norm pointed out, we have very few new positives now. The majority of the tests that are positive that you might see on other statistics are our retests that are retesting positive. But the two recent new positive employees that we've had in the last 3 or 4 days were actually from known household positive contacts. And so we may start thinking about screening for that and using that as an indication for testing. We're also going to be trying to start screening asymptomatic, since we know that there's a significant rate of asymptomatic shedding out there. That said, our strategies, our PPE strategies, and our case and cluster management strategies seem to be overall working because the curve is flattening. So I think overall the trend is good. One other comment, I think we'll hear more about this later, but we're also participating in thinking through how to roll out serologic testing. There's a lot to learn about serology. We're not sure if there's a clinical role yet, because we won't really know what the serology means in relation to infectivity and course of illness at this stage, because it's so new.
Great, thanks so much, Sang. Appreciate it. And Dr. Shen, here are your slides. Pull them up right now.
Great, thank you. Right. Next slide. So I wanted to talk about our surge and capacity planning. And really simply, it comes down to supply and demand. And so some of the guiding principles that we're using in planning our surge is that, first of all, we want to have a tiered approach. It's not going to be an on or off button should we hit that surge disaster scenario. It's going to be a gradual, what we believe to be a gradual spectrum. And so we want to also separate the PUIs and the non-PUIs. We want to try to adhere to that as much as possible for PPE conservation. We want to reserve our rooms for the highest acuity patients. So the patients that are going to be admitted, are going to be intubated. We want to reserve the private rooms that we have for that. Next slide. We want to make use of alternative care spaces. And one of the things that we've been very fortunate, and especially at 300P, is to be able to migrate out to additional spaces that we've identified. So we'll continue to utilize alternative care spaces, which I'll describe in a little bit. We want to continue to utilize the virtual aspect and virtual technology to, again, minimize PPE and healthcare exposure. And the other last tenet is we want to keep all the kids together at 300P. It doesn't make sense to split up the kids between PUI and non-PUI, especially since as a whole, they have not been as impacted as much. So they'll remain at 300P. Next slide. So we took account of all our capacity from the healthcare team side, and we can look at our attendings, residents, APPs, tech staff, everybody, and we can make an estimate in terms of the pool of people we have, in terms of what we currently can staff, what we can flex up to, and we can put in an account in terms of what we think the COVID impact is going to be to our workforce. And that gives us a tally of, again, our current supply. Next slide. We also wanted to take into account how do we protect and workforce as much as possible. And so doing a lot of things around precision scheduling, as much as we don't need a physician or a nurse or staff to be on site. We've been matching our volume, which is much lower than pre-COVID, to the actual demand. And so we've been able to actually remove some shifts off the schedule. And so the people who need to be there can be there. But if you don't need to be there to see patients, then we'd rather have you be at home and be well and be prepared. We have also created several gradations of shifts based on no risk, low risk, and high risk to PUIs. And that allows our healthcare workers who are at a higher risk to potentially be staffed to the no risk or low risk zones. We also are working with the Department of Psychiatry to provide some psychological support proactively. We've read about the PTSD and some of the psychological stress and trauma in some of the other states that have been hit really hard. And so we are putting together, again, with Jose Maldonado's team, some counseling sessions pre-surge, as well as potentially one-on-one sessions during the surge should we hit that scenario. Space is the other major constraint. And in our current 500P and 300P, out of all the spaces that we can care for, we have about 90, about 95-ish, 97 spaces. We figure that we can flex up another 127. And so we can create a total of 222 patient care areas if we needed to. And that's, again, by looking at some alternative care spaces beyond the traditional 300P and 500P ED that you are familiar with. Next slide. And then you've seen these charts already, and so I won't belabor the assumptions that we put into our model obviously has a huge impact on how we plan for the disaster and surge. And so before, we were looking at doubling times at 5 to 6 in the county. Now it's closer to 7 to 8. And then if you look at our doubling time, the next slide, if you use a doubling time of 9, which is what we use for this model, and it's possible we can now use a number higher than 9, but this just kind of shows what our patients arriving in a 24-hour period. The green line shows the total number of patients that would be predicted to arrive. And then each line below shows different types of patients that we would see, whether you're PUI or non-PUI, whether you're high acuity or low acuity. And based on this doubling time of 9, it looks like we would not hit our capacity for another couple of weeks. But again, with more recent data, this number is going to be pushed out much further. And hopefully with the flattening, we may not hit our necessary capacity required. Next slide. And so this is another way to look at our capacity in terms of census. So how many patients are physically in the ED at any given time? And the x-axis is just the time throughout the day. And this curve represents almost any ED in the country. We see a lull around 3, 4, 5 a.m. Then we start to see a rise in the census in the ED as you hit the afternoon. And so again, we assume a doubling time of 6. you'll notice that at least for the 500p adult campus, we would exceed our capacity by midday if we did not surge. Next slide. If you assume a doubling time of 9 days, then it looks much more positive that we will have the capacity at 500p for all the patients that are expected to be in the ED. Next slide. And so when we think about the planning, as I alluded to, it'll be a gradual, or hopefully gradual, but it'll be in stages. We won't expect to go from current to a complete disaster mode, but we'll look at our volumes, we'll look at the predictions, the critical care volume in particular, our space constraints, and then likely we will expand to a surge mode, and then we need to go to a disaster mode beyond that. And so one of the ways we look at our space is, again, by segmenting all the patients coming in based on whether you're COVID, PUI positive, or if you're high or low acuity. And based on these 4 buckets, we are designing the ED to accommodate these 4 buckets because they have different resource utilization needs as well as disposition implications. Next slide. And so if you see, if you recognize our current 500p space, in red, which is the areas we're designating for the COVID PUIs, we have the various zones laid out, Alpha, Bravo, Fast Track, and we can start to consolidate all our PUIs and COVIDs into those red zones. The Delta zone is for non-COVIDs, and then you'll also see the box that says radiology RADs. There's a really nice space there that we've investigated that we'll be able to use to expand into for non-PUIs. And then we currently still see a low acuity PUIs in our garage through our drive-through method, and that's been very efficient. So we'll continue to see the low acuity patients there where, you know, if you are well, you can go home. We've been able to do the test and swab and assessment in 28 minutes is our average length of stay for those patients. Next. And then as we need to expand, we can take over some additional space. And the next would be our lobby and triage, as well as the tents that we would put out as the next phase. In this slide, I just want to mention where we would put the tent if we needed to go beyond the lobby, the triage, and the Delta and the garage space. If you hit the next slide, you see where we have a designated space. So we have a 30 by 30 tent that we can use in a disaster scenario that would be placed right outside our ambulance bay. If you walk out and look to your right, there's a nice landing pad. That's where the tent is designed to go that has the appropriate hookups and electricities and Wi-Fi and things like that. So we can fit about 22 patients in that tent. Next slide. And then should we need to go beyond the surge into a disaster, we would start looking at some additional spaces at 300p, where we could use the lobby, we could use the former Alpha Bravo space that's currently not vacated. We would look into using the Kappa space and the former Fast Track space. And so this would give us some additional capacity to go beyond what we are planning. Next slide. And here's just a visual of the 300p space and some additional areas that we would take over. Some of these spaces we were using in the past when we needed to expand during flu season. I think one last slide. Actually, I think that's it. So again, I mean, bottom line is, you know, we're very happy that we're seeing the curve start to flatten, and you know, it's amazing how even a week makes a difference. Because I shared some of these slides and projections just a week ago, or less than a week ago, and during that time, you know, the outlook is much different. But again, we are glad to be prepared for the worst and hope for the best. But that's our, again, that's a overview of how we are planning to prepare for a potential surge. Thank you.
Thanks so much, Dr. Shen. Next, we'll move over to Dr. Pinsky, who's also joined by Dr. Christina Kong, who's joined us today to talk more about our testing, particularly the PCR test. Thanks so much for joining us, guys. And I'll mention now, since you have the slide, Dr. Scott Boyd as well, who's also going to talk after about the serology test that went live yesterday. Ben, we can't hear you yet. Can you unmute?
Sorry about that. So I will give a clinical laboratory update. Here's the team on the weekend. Can everyone hear me now?
Yes.
Great. Okay. So you saw me go through all the slides already, but our molecular testing is going extremely well. We're still performing the laboratory developed e-gene assay. And we have implemented on multiple workflows in order to eliminate any problems with supply chain. In addition, we've implemented a commercial emergency use authorization assay on the hologic Panther fusion shown here. And that has further increased our capacity. Our capacity now is greater than 2,000 tests per day. Our turnaround time is less than 24 hours when ordering the standard test, with a mean of 9 hours the last time I looked. So we're really moving through these tests and providing diagnoses quickly. I should also say that we have compared the Panther test to the laboratory developed test, and the testing is completely comparable. Over the last several days, led by Jason Kurzer, we have implemented the Cepheid Gene Expert test. This is a 45-minute sample in, answer out test that's being performed in the core laboratory. This can be performed, this can be ordered now as STAT-CoV-2. It's performed on instruments like this with little, there have individual slots that the cartridges can go in. We actually have a larger one to run this test. And as shown here, you add the sample into the cartridge and then you stick it into the instrument. So it's very, very simple and very fast. Our turnaround time right now is about 90 minutes. We're working on methods to improve the time it takes from draw to get to the lab. That's where most of our slowdown is. So on the next slide, we have, here's the indications for rapid testing. The only problem with this test is that we have a limited number of them. So this is being limited to these particular situations at the present time. And you can see those, and those are available on various documents that we can provide. I should say that we have validated the Cepheid Gene Expert test. We are currently comparing its performance to both the laboratory developed test and the other commercial tests that's in our clinical virology laboratory. So we should have more data on a larger set of clinical samples in the coming days. So in addition to providing accurate, timely, and actionable clinical results, we're also facilitating a lot of collaborative research across campus. And this is just, this was made possible by our early implementation of RT-PCR testing and the foresight to collect clinical samples from these infected patients. And you can see this is a partial list of collaborators that are listed here. I apologize if I missed anyone, and I think there's going to be a lot more detail about all of these different projects from Upi and Ken coming up in a minute. There's also a lot of work going on in pathology. In the upper right corner, this is Malay from my research lab, who's looking at the 15-minute Abbott test. So we'll see if those perform reasonably well. But one person I'd particularly like to highlight is the work that's being done by Scott Boyd, which you can see at the bottom there. He's had significant support from Tom Montine as well as Dean Miner to bring up serologic testing very rapidly for SARS-CoV-2. And I think that this work really highlighted the collaborative spirit that we have going on right now at Stanford, and also demonstrates the importance of translational research in clinical pathology. So with that, I'll hand it over to Scott, because there's a lot of really interesting information about the serologic testing that he's going to talk about.
Thanks so much, Ben. I appreciate the information. And as Scott is loading up his slides, Ben, can I ask you one clarification for the new PCR tests? You're working on validating the Cepheid and the Abbott test right now, so we don't know sensitivity specificity yet.
So both of those tests have been validated. We have run the Panther test, Panther hologic test on many more samples, and agreement was greater than positive and negative agreement was greater than 99%. That's on about 150 plus paired samples. The number of samples that we've run comparatively for the expert is much more limited. And so we are planning to run those this week to ensure that the Cepheid is performing as we expect that it will be. So far, the validation samples were in 100% agreement.
Okay, thank you very much. And Scott, are you able to pull up your slides?
I think, Ben, could you stop sharing yours, please? And then I can...
Oh, sorry.
This is Christina. I just wanted to make one additional comment about the Cepheid. It's a PCR assay, and I'm not sure if everyone realizes that. So even though it's in that little small thing, it's actually a PCR assay, and it has a really high limit of detection for the viral copy numbers.
Right.
And the Cepheid Gene Expert is the platform that we use for our respiratory flu testing, for rapid testing for the ED. So it's not an unknown instrument. We have a lot of experience with it, and it works really well. Because I know that there's concern out there about how good is a rapid COVID test, but the Cepheid has a really good track record.
And just to add on to that, the Cepheid assay targets the E gene that we are targeting in our laboratory developed test, as well as the N2 target from the CDC assay. We've looked at the analytical performance of both of those targets, and they're very sensitive. So we anticipate that the Cepheid test will be in agreement with our tests as well.
Ben,
and we are currently running parallel samples, because I know that when the negatives have been coming back on the Cepheid, sometimes people have been ordering a second swab to be run on our in-house. Instead of doing that, you can actually call us, because we are running the parallel sample, so we can tell you what the parallel sample shows.
Great. Can I ask you guys, do you recommend against repeating samples? There's been some question with the clinicians about ordering those tests again. I understand it's about 96% sensitivity for the PCR.
Yeah, so we've looked at the repeat testing, and we've found that most of the repeats are in agreement. So of those individuals who had repeat tests over 7 days, the percent discordance was around 4%. And if we look at 48 hours, it's a little bit lower. It's closer to 3%. It's a little bit challenging to convert that to the sensitivity. It's not exactly 100 minus 4 or 100 minus 3. There's a lot of assumptions that need to go into it. But I think we can comfortably say that the sensitivity of a clinical sensitivity of our assays are significantly better than what's been reported in some literature, and sort of the rumors of 30 to 40% false negative rates that seems to be making the rounds.
Right. Errol, this is Lucy Tompkins calling from home. Can you hear me?
Yes. Hi, Lucy.
I think the more important statistic is the negative predictive value of the test. And that doesn't rely on the sensitivity. That tells you that the negative predictive value, if you put in an approximation of the prevalence of the disease in our community with a specificity, that the negative predictive value is between 97 and 99%. That means that a negative test is truly negative. And I think that's the most important statistic that people need to keep in mind with. There's no need to do a second test if the first test is negative.
Great. Thank you, Lucy. I really appreciate that. Scott, can we come back to you now and talk about serology?
Yes. Thanks. Yeah, can everyone hear me? Or at least those
Yes.
Yes. Okay, good. So I'll give a 5-minute update on the status of the Stanford Clinical Lab serology test for COVID-19. And let's see if I can advance the slides. There we go. Okay, so yeah, if there was an award for the most boring assay in the clinical lab, it would probably be the ELISA that would win, but it's a very robust kind of assay and it can be quite sensitive. It's the way that most of the other viral serologies are performed. So yeah, about 2 weeks ago, Tom Montine asked me to help get involved in implementing a clinical lab ELISA that we could validate so it would pass CLIA inspection for looking for SARS-CoV-2. And just to really briefly recap, the principle is that you have plates that have been coated with the antigen of the virus you're trying to detect. You add the patient plasma or serum. Their antibodies will bind if they're present to the viral proteins. And then you add a detection reagent, which would be an anti-human IgG or anti-human IgM or IgA, depending on the assay, with an enzyme coupled to it that will develop a colorimetric reaction that you can then read out with a basically spectrophotometry. So critical aspects in this kind of assay are the choice of antigen, the optimization of the conditions, including the washes and other aspects of the secondary reagents. And so we had a number of choices. I should say up front that we were guided heavily by some guidance from Florian Kramer's lab at Mount Sinai, who very rapidly shared some initial results that they had obtained testing different viral proteins from SARS-CoV-2 for their use in immunoassays. And I think that was informative for everybody who's worked on this at Stanford. The gist of it is, here's the spike protein with its domains shown. And most of the assays that are being done for SARS-CoV-2 detection of antibodies are either using the S1 domain, which is sort of this first half, or the receptor binding domain, which is this green domain. There's a lot more conservation between coronaviruses and these more downstream parts of the protein, and so they're likely to give more cross-reactivity. So basically the parts of the protein we're dealing with are these green domains here. And why did we pick that for the Stanford assay? Because based on the few reports that were in the preprint literature at the time, it seemed as though it was pretty immunogenic. It's not well conserved between other coronaviruses. There's conservation with the original SARS, but and somewhat to MERS, but not at an extent that would be making it suitable as an assay. And also, a really critical thing is because we needed to develop this quickly and wanted to be able to do it at scale, the RBD protein is actually relatively easy to express in large quantities. Laboratories that have been trying to express the whole spike or even the S1 domain, I think, have had a lot of problems in actually making enough material to do the assay. So this, should emphasize was a real broad Stanford collaboration involving many people that participated critically. I think back a month or month and a half ago, several Stanford researchers, including Taya Wang from Medicine ID and MMI, Peter Kim, particularly the postdoctoral fellow Abigail Powell in his lab, and myself, actually, after hearing one of the very first grand rounds from medicine, realized that there was going to be a need for having serology and producing viral proteins from SARS-CoV-2. And so independently, these groups had started to make them, and I had collaborated with Ted Jardetsky's lab in that effort. So basically, a lot of the pieces were in place to develop a real clinical lab assay at the time, thanks to the efforts of these folks. And Peter had organized a group of discussion for many of the people that were interested in this area that was, I think, helpful in getting everybody organized. So essentially, Taya presented data that showed that the things that were being presented in the Florian Kramer paper worked nicely, and that we could use RBD protein and others for detecting the virus. Abigail Powell had produced really nice, high-quality batches of the protein that we could use for an RBD ELISA. Jennifer Cochran took huge efforts to help make it possible to get larger scale production of those proteins underway, and was helpful at every step. On the pathology side, basically having high quality protein and some good preliminary indications from these colleagues, we were then able to begin developing an assay for the clinical lab that would actually work on the automated instruments that are used to do high throughput testing. And so the person I think who deserves particular notice in this is Kathleen Rutkin, who works with me in the lab. She and I basically spent the last 12 days, day and night, basically testing different conditions to get this to work and get it to be in a nice validated state, with a lot of help from Ben and colleagues, Jim Zander and Tom Montine. So here's the data. So our ELISA has the RBD as the antigen, And we've tested a number of conditions, getting nice secondary antibodies for IgG and IgM. We're developing IgA and think that that should be available relatively soon. And this is sort of a snapshot of the many runs that we did in validating the assay. These are samples from patients that were PCR positive at Stanford, including a negative control, positive control that are on all the plates. And depending on the patient, PCR positivity is often correlated with a strong signal in the IgG antibody levels, but there are occasional patients who are negative by serology. When we've looked at these tend to be people that are earlier in their disease course, typically less than 14 days post-onset of symptoms. We've also looked at a very large number, well, at least 100 patients that had samples collected 2 years ago as true historical negatives before SARS-CoV-2 was around. And we've used them to set the threshold, the cutoff for positivity in the assay. So these are data from IgG, these are data from IgM. You can say in individual patients, we see differences in the G and M levels. And also for additional careful comparison, we've also compared our assay to one that uses the S1 protein, which is that larger chunk of the spike. That's a CE approved device in Europe. This is also a laboratory-based ELISA. And you can see the results from the same samples on that one and ours are really highly similar. All of these are measured in triplicate in each case. And if you look at different instrument runs, they look just rock solid, very identical. So we currently are in the state where the lab was ready to go with the test on Monday. The IT and other issues were completed by Tuesday. And so now we can offer the test. Currently, we think we can readily do 500 tests per day, and that should be able to be increased quite quickly. We've set a turnaround time of 2 to 3 days, which is conservative. And so there's the, of course, major question of interpretation of the results of this kind of assay. And they're really similar to what would happen with any other viral serology, except for the fact that we've only known about this virus for a few months. So if someone has no detected IgM or IgG, or just in bullet points, we would say that this gives no evidence for prior exposure to SARS-CoV-2, but we can't exclude active infection because it might be too early for them to have developed antibodies. And that's actually what we expect in the early days after infection. Patients infected by SARS-CoV-2 can have the IgG negative for even longer. And if you're really concerned about infection, the PCR test based on swabs is the way to go. If someone has IgM and IgG, we think that could indicate early infection. But I think that there's really very little data out there yet for what the IgM time course really is in this condition. So that's something where, as we do the test, we'll learn actually how to better interpret it. And again, looking with a swab is the better way to detect the virus, of course. M negative, G positive, it shows that they've been exposed to SARS-CoV-2. It doesn't exclude active infection, as we've heard that there can be sort of a lingering viral presence in some individuals. And again, correlating to the PCR results is important. There's the big question, if someone's positive for IgG, does that mean they're immune? Of course, there's really no great way for us to know that yet, but a number of studies are being planned to explore that topic in patients who have, or caregivers who have been exposed, have developed antibodies against the virus, to see whether they really are protected against reinfection. And then if someone has both M and G, it's really fairly similar to the G only case. Can't exclude infection, but they may have protective immunity, but that's something we're still gonna have to learn as we go on. And so that's the quick update on what's been happening. We think that based on looking at historical negatives, the false positive rate for this assay is quite low, but we haven't yet had a chance to explore large numbers of samples from acutely infected patients with other coronavirus infections, for example. But we think that at least in the near term, this should be a useful tool for learning what the serological correlates are, and of course would feed into other things like therapeutic plasma treatments and that sort of thing. So maybe I can leave off there and we can have questions later, I suppose. But thanks to everyone who participated in this really big effort, and it's been actually a very enjoyable collaboration despite the time pressure.
Scott, thanks so much for that great overview. We really appreciate it. Can I clarify one question? So if someone has a negative test with the negative predictive value or whatnot, with that confidently, it sounds like this assay confidently would suggest that they indeed have not been exposed, unless they, of course, were just recently exposed and haven't developed antibodies yet.
Yeah, that's what we think. I mean, what I would say, just this is still at the level of anecdote, but patients who have had a mild course or had just, uncertainty whether they really had been sick at all. What we have seen in those kind of examples are that the antibody levels are quite low. So we haven't yet had a big enough study set to really be sure if someone had virally confirmed infection, but a mild infection, what do their antibodies look like at various time points after that? It's possible, and there's some data from preprints that indicate that people could actually have very low levels for quite a long time, over 2 weeks, for example, post onset of their mild symptoms. So that's something that will need to be explored further as we go.
Okay, great. Thank you very much. I want to also thank Doctors Upi Singh and Keth Mahaffey. We had planned to have them talk extensively about research. They have a lot of great stuff to say, and to that end, we certainly don't want them to be rushed. So they've kindly agreed to push to the next week, and we're also potentially talking about doing a town hall on the research realm as well. So they've been leading that, and so apologize for pushing you guys back. They've a lot of great stuff prepared for us today, and they'll share with us next week. I did want to give a few minutes to get to some of the questions as well, and so I'll jump over to the questions right now. Rebecca Levy asks, glad to hear we are so well prepared and staffed, but how can we give back to areas near or far that are not as fortunate? And that's a really great question. Perhaps Dr. Rizk, or yes, Dr. Mahoney.
I was eager to answer that question just because it's something that's near and dear to me as well. And I saw that there were a number of questions just pertaining to the concern that has come out over the last couple of days around health disparities. And so, we're seeing devastating disparities in Illinois and Louisiana and Michigan. And those of us who have experience working on the front lines and HIV will be reminded of similar issues, poor access to testing, poor access to services, and then the economic impact that COVID has had on many families. And so I so appreciate the question. There were a couple of other questions that were along those lines. And early on, when we noticed that there was a testing capacity available, Stanford got ahead of that and started to offer services to frontline first responders in the community, and also to healthcare workers who are not particularly in at Stanford. I feel really happy that I can report out on that and see those activities occurring. I also was encouraged that we have a partnership with Roots Community Clinic. It's in East Oakland and also in San Jose, serving a very indigent population, offering emergency shelter services to homeless. And we were able to, thanks to Dr. Kong and the clinical lab and the testing task force, offer services to testing to those individuals, very vulnerable populations in congregate living settings. And I'm so appreciative to Jonathan Shaw and Kenji Taylor for leading that effort. And then finally, I'll just say that there have been a number of research projects and publications even that has disseminated the knowledge that we have achieved and arrived at within the drive-through testing sites, and then also how we're setting up our services so that, again, that knowledge is being disseminated beyond Stanford.
Great, thank you very much. On that same similar question in the theme of disparities, Linda Wynn asks, California and NorCal is race and ethnicity. Are we seeing racial disparities being reported like in other states in Illinois and Michigan? Do we have any of that data? Does anybody know?
We could easily get the data from EPIC. Of course, I think any of us who have worked with EPIC data around race and ethnicity, there are a lot of problems with that, but I don't think that would be a hard research question or investigation to pursue. But I would imagine, just because of the health and healthcare disparities that exist throughout the country, this area would not be immune.
Thanks, Dr. Mahoney. And just to point out, thanks for those of you who have been answering some of the questions. So those of you, if you can go into the app and see some of the answer questions, I usually go back to those to pull them out, but because we're low on time, I'm just going to keep going through some of the questions, and we have some more questions on disparities, some of the questions that were asked earlier on as well. And I'll also try to get down to some of the more newer questions that haven't had the time to be voted up, particularly probably related to some of the stuff we talked later on. So now that the peak will be earlier and smaller than predicted, which is great news, there are other thoughts of revisiting our transfer policy. I think certainly that is an ongoing thing that as the data keeps changing. Perhaps Dr. Rizk or Dr. Weinacker. Yeah, I think that.
Okay, so this actually hasn't been a very firm policy. We've been deliberative about it, and we're paying a lot of attention to the capacity in other hospitals. One of the issues is very complex care like ECMO. Should that be afforded to these patients? Does it have any value to them is the main question. In Seattle, they decided that no patients would be placed on ECMO, and that's what they did. We've created a consortium with UCSF and Kaiser Santa Clara and CPMC to set standards. So I think we would consider taking transfers of people that really would benefit from being from Stanford. And a separate question is the issue of kind of level loading either in equipment or facilities. As it turns out, only regional medical center is really stressed from a capacity standpoint. And there is a person in the Santa Clara Public Health domain, Jennifer Tong, who's responsible for level loading of facilities. The county is also asking us how much PPE we have and how many ventilators in excess of our needs, which we could extend to other people. And I think there is an active desire to do that level loading. So the specific question of transferring people in is in the context of all of those issues. Kaiser hasn't been interested in transferring patients to us. And the issue of whether people could be on a research protocol if they were here is a real one, and it's being discussed. Valley Care actually also has an IND for the use of remdesivir and is considering also taking patients in for research protocols when they're not available in community hospitals. So this is very much an evolution. Sorry to be so lengthy.
Thanks, Norm, that's great. A question, do we anticipate when the shelter in place will be lifted? I think that's a tough one, and we're not the ones making that decision. Any thoughts on that? I think it's still a moving target, right?
It is, and it's largely controlled by the state and Santa Clara County. And we're developing a task force to work on when we think it's appropriate. And obviously the primary concern is safety of healthcare workers and patients from contagion. And so we're trying to put together what our belief on that is so that we can discuss it with Sarah Cody and Santa Clara County Public Health.
Yes.
Currently, it's till May 3rd in the county, in this county.
Right.
Great. Speaking of Sarah Cody, someone put a shout out to her for all the great stuff she's doing. I haven't even dared invite her to Grand Rounds yet. I imagine she's way too busy, but we've definitely planned to when we think she might be able to join us. Wendy asked really another perfect question. I'm concerned about unequal access to video visits among our patients who continue to drive healthcare disparities. Are we planning to do anything to address assisting our elderly patients and those with limited English proficiency? I know there's been some work on that. Any thoughts, Megan, perhaps?
Yeah. So yeah, thanks, Wendy, for the question. No, I think that's a really important point. And in the video visit platform, I think under the direction of Topher Sharp and all the education that's come out, we are encouraged to convert a video visit over into a phone visit if there are any barriers that present themselves. And so I think we're encouraged, and we have CMS support that will allow coverage of those visits. And so that's very helpful. Interpretation services, that has been a difficulty up until this point, but now that we have platforms like Zoom, or even I hear that there are improvements made so that we can use our current video visit platform, but also bring in interpreter so that we can reduce language barriers as well. So I think that those issues are very pertinent, very important to address, and I'm pleased to see that they have been addressed in a lot of the education that's been provided to providers who conduct video visits.
Great, thank you very much. Next question, maybe Lucy, I have a question here. I've been in isolation at home for the past 3 weeks, as is my son. Is it okay for us to see each other? Dr. Tompkins, it sounds like they've been in past 2 weeks isolation.
Well, considering what the data that we just heard, I don't really know. It looks like that at least the people, our healthcare workers who wanted to return to work, there have been a significant proportion are still positive long after 14 days. And so I would suggest that there isn't really probably a date to know whether they really are able to get back together in the same household. I would guess that they, at the very least, they should be socially distancing in the household, and that if they have common spaces together, I imagine the kitchen is one, that they could do a lot of hand washing. I mean, there's never enough hand washing. As Dr. Fauci said, he washes his hands 50 times a day, and I think I'm about there too. And then just disinfecting, you know, the high touch areas in the kitchen, the refrigerator door handle, the stove, and so forth. And order out if possible so that you don't have to cook. I think it's possible, certainly for people who are in the same household, one of whom is positive and the other whom remains negative. And I know of several cases like that. So I think by now, if they're not sharing any common space, I think it would probably be safe to share common space for sure. When they can leave to go out into the public is a whole nother question. I honestly don't know the answer to that. Maybe somebody else does.
Sounds like we're still learning more about this virus to answer those questions exactly correct, but thank you for that input. That's still very, very helpful. Ken asks, ICUs in the Netherlands are observing that greater than 90% of patients are results of having a BMI greater than 25. Are we tracking any data about that as well at Stanford? Perhaps Anne or I know Norm had to move to another meeting.
I have to say, I honestly don't know.
You know, it might be something that we bring up with Ken and Upi next week as well. It might be one great question to ask from a research perspective. Thanks for asking that question. So next question, are we still expecting a surge in case deaths after the shelter in place ends? That's an interesting question. I think a lot of people are asking, what happens when we remove the shelter in place? I think a lot of it we don't know, but we certainly have more resources at that point. Perhaps Anne, any thoughts on that? I know you've been probably talking about that a lot.
We have, and you know, I think it goes back to, is there immunity? Is there herd immunity? We honestly don't know. And there are certainly, I mean, if you look at Japan, they had a decline in cases and then a resurgence again. So I don't know what we're expecting. So we are preparing for the worst. Our modeling certainly looks a lot better now, and we're becoming a little bit more relaxed about it, but we're not completely relaxed and don't know what necessarily to expect. And even if we have antibodies, what does that do for us? We don't really know.
Well, Errol, I recently read something that suggested that at the most, you know, maybe 3% of the population might have antibodies, because we know that the vast majority of the population has not been infected, and therefore, if you talk about herd immunity for other viruses, you need to be way up there. Maybe not to the 97% level or the 95% level that you would need for measles, but who knows what the herd immunity level would have to be in the population. My guess is that we're all going to be wearing masks for a long time and practicing hand hygiene for a very long time, if not forever. And that maybe our practices that we have learned in this era will continue to extend to what we do outside of our home and at work.
And Dr. Thomas, one of the things that, again, perhaps Ubi and Ken will talk about more is we have research, Dr. Aaron Ben-David's doing Sero-survey data, and we'll try to get him to come present that as soon as we have it. So we'll learn more about the prevalence, hopefully in the upcoming weeks. Sang, you wanted to make a comment on household contacts?
Yeah, just this morning, Santa Clara County issued a new directive quarantining all family and household contacts of known positives for 14 days as well. Interestingly, the last two employees, healthcare workers that came out positive in our screenings were from family household contacts. And so I think that's probably the right direction to take. We're going to have to figure out how we implement that in our own healthcare workforce, and that'll have some impact as well, but it's probably the right thing to do.
Okay, great. Thank you so much. Okay, guys, thanks for sticking with us today. We had to go a little bit over, but we wanted to get some really important updates in. Again, apologies to Ken and Upi for, we'll definitely get you in next time. And thank you, everybody, for joining us again. Please keep us updated on how we can best provide these updates in grand rounds. And we're working on providing some additional town halls as well. We'll send out notifications on, particularly on everything from research, as well as working with our team, Nick and Shaw, and the group with modeling as things keep updating every day. So that's it. Thank you so much for joining us. Hope everybody has a good rest of the week. We'll see you soon.
Thanks, Errol.
Bye.
Thanks, everybody.
Thanks, Errol.